afternoon, everyone, and welcome to our Lynn Cancer Institute Physician Panel Series. Today's topic will be Understanding Head and Neck Cancers from Diagnosis to Treatment. We will be learning from our speakers, Dr. Micah Glahn, Head and Neck Surgical Oncology, Dr. Ross Taylor, Radiation Oncology, and Dr. Mathin Matthew, Medical Oncology. We're very fortunate to have these physicians who work with our head and neck cancer patients, experts who are deeply committed to improving the lives of these patients in our community. At the Lynn Cancer Institute, we believe that education and awareness, prevention, screening and early detection, a variety of treatment options, our latest technology, the expertise of our staff, and as we're seeing today, the benefit of our multimodality method of treatment, all combined, will truly make a difference in the lives of our patients. In the interest of time, our speakers' bios were sent to you by email. During their presentation, we invite you to please take notes, and if you have questions, please add them to the chat box or the Q&A box, and they will have time at the end of the presentation to answer any of your questions. We're very proud to welcome you to the Lynn Cancer Institute and introduce our first speaker, Dr. Michael Glahn. Dr. Glahn.
All right, good afternoon. Thanks for everyone for tuning in. We're going to get started, and much of what I'm going to say is just talking about how we have such a great comprehensive team here at Lynn and all the opportunities that our patients are afforded, and frankly that we're afforded as their providers. So first of all, what is head and neck cancer, and why are we subciting it based on one part of the body? Well, typically it can involve this entire region. The sinonasal is uncommon, but we do see that. And then oral cavity can progress with an oropharynx, larynx, or another way of saying that is just vocal cords. And then the salivary gland. So that's your parotid glands here in your face or your submandibular. A lot of skin cancer, especially here in our area. And then sometimes progression of cancers within the lymph nodes of the neck. And lastly, an encompassing of thyroid cancer as well, so your main metabolism gland. It takes definitely a huge team to make sure that our patients can have the best outcomes. And I want to take a moment to just talk about those members of our team and the strong care that we're able to provide as a group. So surgical oncology will be the focus of what I chat about, but you'll hear then afterwards about radiation oncology and medical oncology. But other physicians involved, certainly our endocrinology team helping in maintaining an endocrine balance, whether it be after a thyroid surgery or sometimes after radiation, we need support for thyroid supplementation in that sense. Our radiology and our pathology teams are critical. I have worked throughout this country and I'm just really happy with the quality of care that we're able to give with the radiology and pathology teams. It really takes a village here. And our radiology and path teams come together with all the teams here you see, not all of them, but a large number here, weekly at our tumor board. Tumor board is a conference where we get together as a group, talk about all of the new cancer folks that may have come through, or perhaps just talk about any of our cancer patients who are actively ongoing with treatment and who may need a little bit more focus from the team. So our radiology and our pathology colleagues are there, medical oncology, radiation oncology, and then we all often have social services involved at that time, and our nutrition team comes as well, as in addition to nurse navigators. We have a great interventional radiology group that helps when we need biopsies to try to get those done in a timely fashion. And then critical to oral cavity cancer, oropharynx cancer, larynx or vocal cord cancer is having a strong speech and swallow therapy program. And we've been doing that through the Gloria Drummond Center with an additional speech therapist hired this year, and just a really high level of training amongst those therapists. They're doing a great job. And I've seen, one patient that comes to mind is a patient who was radiated 20 years ago, which is a severe amount of radiation to the tongue, and has really struggled with swallow. And I would say after about 3 months of swallow therapy, has seen leaps and bounds of improvement. So despite the chronicity of her problem, the therapists that we have been able to really rehabilitate and help. Lymphedema, we have therapists here locally. We have therapists throughout the Baptist system who often are also involved in tumor board and have just been advocating so well for the patients. There's a company called FlexiTouch, which is it's a pump system that the patients can wear to help reduce lymphedema or swelling of the lymph nodes. And getting coverage of that from insurance is really difficult, but our lymphedema team has been able to really do an amazing job in advocating for patients and getting them that wonderful tool. Of course, have to give a little thank you as well to our inpatient team and our social work team and all the nurse navigators. Most of my patients postoperatively will be up on the 8th floor. That is the oncology unit. And I've seen just some excellent care from the nurses there, and looking forward to seeing the new units as the new hospital opens up progressively. So how do we prevent head and neck cancer? Sometimes we can't, okay? And that's the really hard reality, is that unfortunately there are many visits where there's really no reason why this is happening. But there are some components and some things that we can talk about in terms of prevention. And particularly if we're chatting as a community here, I think it's important we go over those. All your doctors will tell you, but of course, smoking and alcohol, that's a big no in the head and neck cancer range. Anything that your smoke touches is going to put you at a high risk of developing cancer. So definitely the mouth, definitely the vocal cords and the tonsils, the base of tongue, goes without saying, but esophagus and all of that. Alcohol, same thing, in excess. Needs to be really, we have to be very careful as it comes to that. A balanced diet is really important, and part of that is just making sure that you don't have an excessive amount of acid reflux. We're seeing a lot of acid reflux kind of worsen in the last, I would say maybe year, because of the high use of GLP-1s. And it's important that if you're using those medications that you try to have something to reduce any reflux, because chronic acidity coming up from your stomach and burning your vocal cords can be detrimental to your health. So if you're on one of those, just try to make sure that you're not having bad reflux. And if you are, try to get on appropriate medication for that. Or there's also some supplements that can reduce reflux so you can avoid medication. Regular dental visits, I just have to really commend all the dentists in the community. They are the people who tend to see inside people's mouths more. If you're going every 6 months, as you should, they will always examine the tongue, and that's helpful in prevention. And then HPV vaccination. So HPV is the human papillomavirus. And the human papillomavirus is commonly known to cause cervical cancer. And while there is surveillance for cervical cancer via pap smears, which women will be getting very frequently, there is no surveillance for the oropharynx, which is to say there's no way of swabbing the tonsils and the base of tongue at the current in the current scientific community. So it's something we would love to see, but we're not seeing that quite yet. And in the meantime, would highly, highly recommend HPV vaccination. The HPV vaccine is approved by insurance up until the age of 45, and we recommend that children begin to just formalize their vaccination around the age of 12. So typically this is something that is done in the pediatrician's office, but if you're an adult and you're under the age of 45, you can still have this done. So then we move on to the surgical oncology group. We're a really large group of ENTs here in the community, and have a great office where we really try to make sure that people are seen in a convenient fashion, in an expedited fashion, and that we can offer as much as possible the day of the first visit. If someone comes in with a tonsil mass with a really high suspicion for cancer, they will get a full examination and a biopsy on that day, and most likely an ultrasound of the neck as well to assess for any lymph nodes involved with cancer. So we're just trying to get point of care as quickly as possible so that as soon as we find the cancer, we can treat it at the stage it's at and not have any progression of disease. In the office, we have high definition scopes or little cameras that we can use to monitor any tumors or monitor any precancers. We have a wonderful speech pathologist who also can provide stroboscopy, which is the same thing as a high definition camera, but the light is in tune with your voice. So it's like a little strobe light and allows for great evaluation of the vocal cords to improve swallow and speech. We have scopes that we can biopsy in the office through. And as I mentioned before, an ultrasound, and the ultrasound will allow for different types of biopsies. We also have a CT scanner in the office, so we can offer imaging of that modality as well. And so all of that can happen day of your visit. Getting to the operating room. So it's important, and as a head and neck surgeon, to address the patient and make sure that we can get them back to their same functional status, no matter the site of cancer. So whether it's the tongue, which obviously is critical for speech and swallow, or the face, which is critical for one's self, confidence and one's connection with others, we try to really minimize the functional hit that we give patients and minimize the cosmetic impairment that we give patients. So, do the best we can as a reconstructive team and to try to minimize the deficit we have to cause with the oncologic portion. In doing that, one of the things that is important is having whatever state-of-the-art technology we can get our hands on. So we're using a lot of intraoperative nerve monitoring, whether that is for the vocal cords, if we're doing thyroid surgery. The vocal cords come right here on the thyroid, and it's very important that we monitor those. Or whether it's for the face and the facial nerve, doing a lot of parotid surgery and making sure that we're able to clear aggressive parotid cancers without having any facial paralysis. So we have intraoperative nerve monitors for that. And then we just secured what's called the PTI, which is a parathyroid monitoring machine, which is fantastic. Really grateful to Baptist for securing that. And that's to help maintain calcium balance for patients undergoing thyroid surgery. In terms of minimally invasive surgery, we are doing a great job with primarily our transoral robotic surgery program, but I've listed there a couple of other opportunities that we have and offerings that we have as relevant to patients. So that's laser microsurgery for the vocal cords as needed, endoscopic skull-based surgery, so helping with the neurosurgery team to access the brain or the pituitary through the nose, which is amazing surgery that can be done, and then coordinating with our local dermatologist. Talking a little bit about transoral robotic surgery. So we launched the program at Lynn Cancer Institute this past year and have been seeing wonderful results for our patients. The idea behind transoral robotic surgery is for patients who in the past were not able to have surgery because the tumor was too far away. We now have a robot that can enter into the base of tongue and the tonsil area and allow the surgeon who you see sitting here on the left side of the screen to act as if their head is deep in there and address the surgery in such a fashion where we really have not been able to before. This is a level of care that is often reserved for academic institutions, and we're now able to provide that here at the Lynn Cancer Institute. Prior to this, patients would have had to just have radiation because the surgeons would not be able to access those sites. And A lot of that radiation can be very difficult because it's on the tongue or on the tonsils, and it can be very difficult to go through. So now that we can offer surgery, in some cases, we are able to reduce radiation or completely get rid of radiation for specific patients. So this is our celebratory day when the program was launched. We have Dr. Taub, who's our chief of robotic surgery, in the blue, and then we have Dr. Young in the green here, who came down from Miami Cancer Institute as a proctor, and then our wonderful surgical team who, again, I've worked at a lot of hospitals, and this surgical team and operating room team is just fantastic, second to none. So it's a great honor to work with them, and so much empathy in the team, and just a high level of excellence across these providers here. Last thing I'll talk about is surveillance, and that's something that I think is incredibly exciting, kind of new era, and that I've been learning leaps and bounds about this year as the technology advances. So, of course, your head and neck surgeon or your ENT will be doing very close surgical follow-up, meaning if you are cancer-free or when you are cancer-free, you will see them every 3 months for the first year. And then usually I do every 4 months the second year, every 6 months until the 5th year, and then annual for the rest of their lives. We'll do imaging as needed, so CT scan or PET scan depends on the case. And of course, in-office ultrasound can be used to try to reduce excess appointments. But what's incredibly exciting is serum surveillance. So blood tests used to surveil whether a patient is cancer-free or not. And this is a totally expansive portion of the scientific community right now. And I think we're going to continue to see great things in this realm. There are a number of companies listed here, but basically one of the companies works with the human papilloma virus and the way that it sheds into the bloodstream, and it can detect any cancer recurrence, which is amazing. And it's something that basically was developed in the last 4 years and now has really started to take hold in the medical offices, thankfully. And then the other two companies are actually taking patients' tumors and creating an assay specific for that tumor, specific for that patient. And so the patient will have their own blood test. I liken this to the PSA in prostate cancer. It's not exactly the same, but they always had a blood test, or thyroglobulin for thyroid cancer, another blood test that folks would have that they could say, okay, am I cancer free? I'll go for my blood test. We never really had that in head and neck cancer. And so these new companies just give a lot of hope to helping us really have strong surveillance. And if, God forbid, a recurrence should come, giving us the ability to intervene early. Lastly is survivorship support. So making sure that we don't feel like we're underwater once we're done with everything. So we're trying to ensure that after your treatment, not only are your visits talking about surveillance, meaning, okay, do I have any cancer, but making sure that any other therapy you need is addressed. So, speech and voice rehab, swallow, lymphedema support. We have really beautiful hyperbaric oxygen chambers at Gloria Drummond. If any wound care is needed, fantastic nutritionists who are specifically focused on the oncology. We have an amazing palliative care team, and the palliative care team will make sure that your pain is well controlled. And if pain is all well controlled, to make sure that any depression and social issues may be addressed as well. And then, of course, if we need to do any restoration surgery for the voice or the face, we can provide that as well. I'm going to stop sharing my screen and look forward to questions. For now, we will transition over to our next speaker.
Okay, good afternoon, everyone. Okay, thank you, Dr. Glahn. Really important points that Dr. Glahn made. I mean, this is such an important part of head and neck treatment, to have this collaborative group that we do here It really takes a village in terms of treating our patients. And so thankful to be part of this team, and thanks to everyone who was part of this team in helping with the treatment of our patients. So I'm a radiation oncologist here at Lynn. Wanted to discuss just some very basic principles of radiation, because I think oftentimes we get lost in terms of what radiation really is. Want to talk about some technological advancements that we have here at Lynn in terms of improving outcomes in patients with head and neck cancers, reducing side effects, and then briefly touch on some updates within the department for 2026. So really basic idea of what radiation is. I mean, it's essentially a packet of energy that travels from one place to another. And there's radiation everywhere in the world that we live in. Oftentimes it doesn't cause any harm. As you can see here from the electromagnetic spectrum, from grade school, you have radio waves that have a long wavelength, but as we shorten that wavelength, we get increased energy, and then we get into the realm of ionizing radiation, which is what we consider therapeutic radiation. And so from the schematic here, you can see this packet of energy, or a photon, interacting with matter. So it interacts with this electron. The electron jumps off of the atom and then binds to a water molecule. That water molecule then becomes what we call a hydroxyl ion. That ion is able to interact with the DNA. It breaks the DNA. So in the context of oncology, we're breaking the DNA of the tumor cells. The tumor cells then go on to a programmed cell death. So we kill the tumor cells. The direct action is very similar. We have a packet of energy. It interacts with an atom. The electron jumps off of the atom and interacts directly with the DNA, killing the tumor DNA and essentially killing the tumor cells. So for head and neck treatments, there's a vast array of treatment sites that we use radiation therapy for. In the definitive setting or the curative setting, oftentimes we collaborate with Dr. Matthew or one of his colleagues and deliver the radiation concurrently with chemotherapy. So we treat the oral pharynx definitively, the nasopharynx, locally advanced laryngeal cancers, as well as early stage laryngeal cancers, as well as skull-based lesions. In the adjuvant setting, which means generally after surgery, we oftentimes are treating post-op oral cavity cancers, salivary gland cancers, as well as nasal cavity and sinuses. Very rarely are we using radiation for thyroid, but there are instances where it is indicated. And then lastly, palliative treatments. So for patients with symptomatic lesions that may not be appropriate for curative treatments, radiation is an excellent modality in the setting of symptomatic improvements, as well as metastatic disease. So not necessarily treating in the head and neck. If the cancer has spread to other organs, radiation can be used effectively for symptom management or slowing progression of disease. So why has radiation and treating head and neck cancers been so difficult historically to treat? Well, I think the schematic really sums it up nicely. There's a lot of important real estate in the head and neck, right? So, starting from the top, we have the central nervous system, the brainstem, the spinal cord, the optic structures, the hearing structures. And as we get down further into the face, we have the mucosa, which is very sensitive to radiation. We have the bones that are really important for eating, right? The mandible, the teeth. All of these structures are really important for living life and your quality of life. And so the struggle has been, we know that we can get radiation to a tumor, and we know that we can kill the cancer, but we need to try and limit the side effects. And so over the course of the last 20 or 30 years, the goal has really been, how do we continue to get the appropriate doses to kill the cancer cells, but limit sort of these side effects that can happen in the acute setting during treatment, but can also be life-changing, right? We can have symptoms, as Dr. Glon mentioned, one of her patients, you can have symptoms that could potentially last a lifetime and ultimately affect your quality of life. So really the goal has been to, make more precise treatments, and we do that with technological advancements, better onboard imaging, combining our radiation treatments with chemotherapies or immunotherapies, as Dr. Matthew will likely touch on. And then we look at things, well, are we treating to doses that are too high? Are we going to get the same result from maybe lowering the doses? Or are we treating larger volumes than we necessarily need to? So all of these things are in play in terms of how we advance definitive curative treatments for these head and neck cancers, but also with the goal of limiting side effects. So just for historical context, I wanted to show you some images here. You can see here where it says 2D. This is how we treated patients probably up until the late 90s. I mean, these are X-rays that we would actually draw on. So the actual films, you can see here in the red, this is the target that is being delineated. And then these drawings here, the black sort of marks, are what we call blocks. And so these were physical lead blocks that would be made to put in front of the beam, and the beam would sort of just be shot at the patient. And ultimately, you can see there's a lot of normal tissues that aren't being protected. And so as we got technologically more advanced, we transitioned to something called 3D radiation. And you can clearly see here the difference, right? We've got a CT scan, but we're still pretty crude in terms of how we're treating. So we've got two lateral beams coming in here, and all of this red, this is the high dose region. And so you can see that ultimately we're still treating a large portion that doesn't necessarily need to be treated. The spinal cord's involved here, maybe the tumor's on the left side, and we don't need to be treating over here. And so again, we were pushing forward to get more conformal plans, limit the normal tissues that are receiving radiation. So what I wanted to do is I wanted to highlight sort of the arsenal of radiation treatment modalities we have here at Lynn. We are incredibly fortunate to have the technology that we do here. Many institutions only have one machine, maybe two if they're lucky. And so we're really fortunate that we have these machines, and I want to put it in the context of how we use them, particularly in head and neck cancers. So we have, starting off with the TrueBeam, we have 3 TrueBeam machines across our centers, one in Delray, one in Boynton, and one in Boca. This is really the workhorse, the gold standard in terms of radiation care, especially for intensity modulated radiation therapy, which is essentially this dose painting type of radiation that gives us really nice conformal plans, limiting dose to the normal structures. It has really good onboard imaging, so we can see exactly what we're treating on a daily basis. Again, it's widely available. We have 3 of them. So if you live in Boynton, we've got a center that has one. And so the convenience of this machine is wonderful as well. As with anything, these machines have their limitations. The limitation of a TrueBeam is in certain circumstances, as is with any photon radiation machine, we have exit dose. And so if you're near an organ at risk, a critical organ, sometimes that exit dose is not going to be appropriate. And so there are other modalities that may come into play and may be better in certain circumstances. The next machine that we have in Boca is called the RadExact. This is a tomotherapy unit. That just means it's essentially a CT scanner that also delivers high dose radiation in the therapeutic setting. This machine's excellent for treating head and neck cancers, especially large fields where we have bilateral necks that need to be treated. The plans are really conformal. The dose is really homogeneous. So we get these really tight plans that really carve around the tissues. The downfall of this machine is sometimes the treatments are a little bit longer than say on the TrueBeam. And then ultimately, as the dose falls off, we do have some structures that sort of give this low dose radiation bath. Oftentimes not clinically relevant, but certainly something that we as radiation oncologists care about and keep a close eye on. The next treatment machine we have in Boca is the CyberKnife. Now, in the context of head and neck, we don't generally use this very often. There are very specific circumstances that we might use it, usually in the reirradiation context, small recurrences. And the benefit of the CyberKnife is it's sort of this robotic arm machine here, and it really has the ability of all these different degrees of freedom to deliver the radiation with sub-millimeter precision. So limited use in the head and neck space. However, there are those isolated cases where it can be really valuable. The next, I think our department is really excited. The Proteus One machine, it's our new proton unit that will open next month. And we're really excited. I think there's a lot of emerging data in support of proton therapy in head and neck cancers, particularly in reirradiation cases, in ipsilateral treatment, which means just one side of the head and neck or face compared to bilateral. And so we're really excited to add this to our arsenal. It's going to be really fantastic for our patients. And the benefit of proton is the inherent sort of properties of the proton particle is that we don't have that exit dose that I've spoken about. And so we really have the ability in the context of treating one side of the neck and not having this spill of dose to the contralateral side that obviously we worry about acute side effects as well as the long-term side effects. And then lastly, we have a machine called the ViewRay. This is in our Delray site, another really fantastic technology which uses MRI guidance. Again, in the context of head and neck, we really don't use it frequently, but I think it's sort of an emerging interest in the head and neck space in terms of adaptive treatments. So the ViewRay has the ability to really give us great resolution of soft tissue structures. It gives us the ability to adapt treatments on the fly on a daily basis. And so that's a really unique property and a really unique thing in radiation oncology. Up until 5 years ago, that was not something that was available. So as you can see, we really have an incredible amount of technology, all of which is very specific and beneficial depending on very specific circumstances. So I just wanted to very briefly, I know I'm probably running out of time here, sort of give you the context of what this means, right? And so as I showed you before, this image A, this was the 3D treatments that were being used in the early 2000s, where you have these two lateral beams, very crude treatment where we're treating a lot of the head and neck region. Here is what an IMRT or a VMAT plan looks like. So the TrueBeam, for instance, or the RadExact, you can see the red, all of this red is sort of the targeted area. So we're not treating all of this extra tissue. And so we get this really nice dose painting effect with these treatment machines. But to the point that I've already made, you see all the blue and yellow sort of encompassing the rest of the head and neck region. Well, that's that low dose that I spoke about. And so, obviously we're seeing some low doses here, oftentimes not clinically relevant, but again, something to point out about these machines. On the right here, we have an adaptive treatment. Again, this is sort of an area of interest in the head and neck space. The first image here is the original plan. And so for daily treatments, we expect the plan to be the same. However, in reality, that's not always the case. So if we look on the far right, this is sort of the non-adaptive plan. And what I want you to pay attention to is this yellow circle. Okay, that's the spinal cord. You can see that the dose is carved around it. As we look at the non-adapted plan, well, for some reason, there's been a shift in the anatomy, and now that plan is sort of encroaching and treating the spinal cord, which is what we don't want. And so an adaptive plan would say, okay, well, we're going to adapt on the fly, and the middle plan is sort of what that looks like, right? So now we've carved out the spinal cord, and we still get this really nice dose distribution of radiation. Okay, lastly, because we're so excited about the proton center, I think this is a really nice example of where we see benefit in proton therapy. And so I want you to pay attention to the image on the right here. So the far right image here, this is a typical photon plan. So we can see we're treating a postoperative parotid, and here's the delineation of what we want to treat in the red. And the photon plan, you see all of this exit dose sort of covering the entire head and neck region. And that's typically what we see in photons. Well, if we're treating the ipsilateral parotid bed with protons, look how beautiful this sort of stopping of the radiation is, right? We have this stopping power of protons. So all of this normal tissue is being spared from the radiation. And so that's a really sort of nice example and really exciting in terms of how we're going to use this technology to treat our patients. So again, we're really excited to be adding proton therapy to our arsenal of treatments here in Boca and at Lynn Cancer. And so here's to the future. We're excited. Thanks, everyone.
All right, great. Thanks so much, Ross. Good afternoon, everybody. My name is Mathan Matthew. I'm a medical oncologist here at Lynn. And today I'm going to focus on what's new in medical oncology for head and neck cancer. And you've already heard about the surgical perspective from Dr. Glown and radiation oncology from Dr. Taylor. So the biggest update from a drug standpoint is really that immunotherapy is no longer used just for recurrent and metastatic disease. We're now using it earlier in curable head and neck cancer, particularly in coordination with surgery. I just also wanted to briefly go over a quick roadmap of how drug therapy is used in head and neck cancer. And, you know, these drugs, and when I talk about drugs in general, I'm talking about chemotherapy, immunotherapy, and also targeted therapies. They can be given for surgery or radiation, and they can be given before that, in which we call it neoadjuvant therapy. They can be given after surgery or radiation, which we call adjuvant therapy. Or they can actually be used both in both situations around the time of surgery, which is termed perioperative treatment. And when chemo is administered definitively with radiation, we call it concurrent therapy. And lastly, if cancer is spread and can't be cured, local therapies are often the mainstay of and cannot be used. Drug therapies are often the mainstay of treatments, and that's really where we've had immunotherapy in the past. And just briefly, immunotherapy works differently than chemo and targeted therapies. Rather than directly attacking cancer cells in a traditional way, it helps the body's own immune system recognize and fight cancer effectively. The two main drugs that I'm focusing on today are pembrolizumab and nivolumab. And they both are termed checkpoint inhibitors because they work by removing the brakes or the checkpoints that prevent immune destroyer cells, such as CD8 T cells, from attacking cancer cells. And one of the most notable pathways is this PD-1, PD-L1 axis here. And a lot of times you'll hear us talk about a PD-L1 score, and that's actually an immune score that we actually check on tumor cells to see the distribution of this receptor. And we think that if there's a lot of distribution of the receptor or high PD-L1 score, that these drugs have more efficacy. Both drugs were important in the recurrent and metastatic setting, but now they're moving into earlier lines of treatment. And one of the key ideas here in head and neck cancer is the perioperative immunotherapy can be very effective. Partly that means that treatment given around the time of surgery, and the thinking here is that surgery as the only first step is what we classically would do first, but now if we can give immunotherapy before surgery, with the idea being, can we prime the immune system to recognize these cancer cells? And there's a lot of advantages to that. One, we can understand biologically whether the tumor is going to respond before the time of surgery, and we can actually see it because we'll remove it at the time of surgery, and we can see if there's going to be an immune response. And that's helpful in understanding the prognosis as well as the predictive value of immunotherapy. In addition, after surgery, we continue immunotherapy, and the idea there is to try to stimulate an anti-tumor immune response that can act as almost of a surveillance mechanism and lead to improved cure rates. And so this is gaining much more popularity. And one of the important questions is, does it work? And so to answer this question, researchers conducted a large phase 3 study called the Keynote 689 study. And in this trial, patients with locally advanced stage 3 and 4A head and neck squamous cell carcinoma, and I'll say most of these were oral cavity tumors, who were considered to be surgical candidates, were randomly assigned to receive either neoadjuvant pembrolizumab for 2 cycles or upfront surgery. And after surgery, they would receive either the standard of care, which in this situation would be radiation therapy in the adjuvant setting, plus minus chemotherapy, usually with cisplatin, or that same treatment in conjunction with pembrolizumab. And in the experimental arm, pembrolizumab was then continued for a total of 12 cycles, or about a year total. And the endpoint here was event-free survival, which is, in plain language, means how long patients stayed free from recurrence or another major cancer-related event. And in addition, they stratified patients based on whether or not their immune score, which I mentioned, that PD-L1 score, was high or not, and also based on their tumor stage and site of origin. So what did the study show? Well, we found that event-free survival was improved with the addition of pembrolizumab. And in particular, at 3 years, about 60% of patients who were treated with pembrolizumab did not have disease-free events or disease-related events, versus about 45% of patients who received standard of care. That's a substantial and clinically meaningful improvement. Furthermore, serious treatment-related side effects were overall similar between the two groups. And I do want to mention that immunotherapy is not without side effects. The immune system is a powerful weapon against cancer, but can also at times turn against a patient's own body, and these drugs need to be monitored closely for toxicity. So importantly, this was a practice-changing study that actually led to the FDA approval of pembrolizumab around surgery for selected patients with resectable disease, and it's now the standard of care in this setting. Another important question is slightly different. Keynote 689 asked whether immunotherapy helped before and after surgery. The NIVO post-op study was done to understand whether or not patients who already had surgery and had high-risk pathologic features would benefit from immunotherapy. So this is not exactly the same strategy. It's a post-operative intensification strategy. This study compared the standard post-operative chemoradiation with or without nivolumab, which is another immune checkpoint inhibitor and a PD-1 inhibitor. In the experimental arm, nivolumab was added to post-operative treatment and then continued afterward for about 6 months. And the primary endpoint here was disease-free survival, which is similar to event-free survival, but essentially starts treatment at the time of surgery. But researchers did also look at overall survival, which is really our gold standard, because we want to know whether or not patients can live longer with our treatments. So what did they find? Well, this is also a positive trial, and median disease-free survival was almost 4.5 years with the addition of nivolumab versus 2.5 years with standard of care therapy, which is a dramatic improvement. And overall survival, while the data is still immature and has not been presented yet, is promising. And the way I would represent that is these Kaplan-Meier curves. You can start to see these curves start to separate, and that's usually an indication that there'll be an overall survival benefit. However, I would mention that this is not FDA approved yet. So while this is promising phase 3 evidence that immunotherapy may improve outcomes after surgery in higher risk patients, it's not yet FDA approved, so it's not quite established at the standard of care yet, but hopefully it will be soon. So I'm going to end with 3 take-home messages here. First, surgery, radiation, and chemotherapy still remain the backbone of curative intent treatment in head and neck cancer. It's more important than ever that a multidisciplinary team that we have here at Lynn, can evaluate patients together to come up with the right treatment approach. Second, immunotherapy has now moved into the curative intent setting. Pembrolizumab was FDA approved last June for the treatment of patients treated with surgery with potentially resectable disease. And third, nivolumab, Nivo post-op suggests that immunotherapy may also improve outcomes after surgery in higher risk patients. But right now, that approach is not FDA approved, so we await the final step before using it in practice. The larger story here is that immunotherapy is moving earlier in care with the goal of reducing recurrences and improving long-term outcomes. So with that, I'm going to stop, and I think we have some time here for questions.
Thank you, doctors. We don't have any questions yet, but we have a couple of thank yous. And I have to say, doctors, we learned a lot about head and neck cancer, but I think each one of you educated us so much further than that on each of your specialties. And thank you for that. This was very informative. Yeah, everybody's like incredibly informative. Thank you. Great presentation. Lots of kudos coming in. And so we really appreciate all this amazing information. And I think this was a great showing. And I want you to know that almost 50 people were in on this lecture, which is, yeah, they're still coming in. Excellent presentation. So we really educated a lot of the community as well as our employees. So we're very grateful for all the time. We know how difficult it is to do all the research on this and put it together. The thank yous are still coming in. I hope you can see them all.
Yeah, thank you all.
Yeah, everybody's very grateful. And I want everyone on this presentation to know that this was recorded. So if you do want to review it again, if you want to pass it on to patients, family, friends, anybody that you think would benefit from this education, it should be ready at the beginning of next week. Lee will be sending out an evaluation, and as always, we appreciate your feedback on that, and the doctors appreciate it as well. And at this time, you can ask for a copy of the link or ask any other questions that you might have. So next month in May, we're going to be focusing on brain cancer on May 13th, on May 15th on skin cancer, and May 20th will be our nutrition presentation. So thank you, everyone. Thank you, everyone who joined us, spent your lunch hour with us, and have a great rest of the day and weekend. Doctors, thank you very much.
Thank you.